Hi everyone, and thank you for joining us for part one of our three-part webinar series on finding the root cause of the medically unexplained. Our webinar will be starting very shortly. I appreciate it's a beautiful warm day today, so thank you, and we are very grateful for you for joining with us. Before we kick off with today's session, just a small piece on the series itself. So we're often in conversation with a lot of practitioners, and we felt there is a growing awareness around us. People outside of functional health are starting to take note of what functional medicine can really do. And we just want to fully explore and celebrate that a lot more. So according to the NHS, about 1 in 4 people who see a GP in the UK have physical symptoms that can't be explained. Headaches, stomach troubles, physical pain, faintness and heart palpitations, all of which at best are worrying to our patients, but at worst life-altering and immobilising to some. And just because general practitioners are currently unable to access those resources to help them find a condition causing these symptoms, we know that it doesn't necessarily mean that nothing can't be done to help. So our webinar series is, as it says in the title, all about finding the root cause for the medically unexplained and taking the experience of reputable fellow health professionals to explore client case studies and innovative treatment processes that go beyond symptom management. So today's session will be all about chronic fatigue syndrome, and following that we'll have a session on IBS and fibromyalgia as well. So if you haven't yet registered to all of the sessions and you would be interested to, please just visit our website or the Instagram bio to register. Alternatively, you can access them all using the link that you've just joined us with today. So without further ado, I'd love to introduce our host for today's session, Lauren Windas. Lauren is a renowned registered nutritionist, naturopath, author, and co-founder of Ardere, a holistic wellbeing company specialising in wellness and natural non-toxic self-care products. So Lauren works a lot with clients who suffer with CFS, ME, and post-viral fatigue-related conditions such as IBS, and as well as those struggling with their weight or poor relationship with food. Lauren is also qualified as a master practitioner in eating disorders and obesity with the National Centre for Eating Disorders and is additionally trained in NLP. So Lauren journeyed into the world of wellbeing and nutrition at university and has recently published her book, The Chronic Fatigue Syndrome, Your Route to Recovery, which I'm sure Lauren can tell us more a little bit about later. And we're thrilled that she's joined us today. If you do have any questions, please just drop them in the chat box throughout the session. We'll come round to them at the end. But for now, I've spoken far too much, and I'm going to hand over to Lauren. Hi, Lauren.
Hi, Amelia. Thank you so much for that introduction. Let me just swipe onto my next slide, which, to be fair, you've already done the intro for me, but I'll just kind of reiterate. So, hi, everyone. My name is Lauren Windas. I'm a registered nutritionist, naturopath, also author of Chronic Fatigue Syndrome, Your Route to Recovery, which is obviously very aptly titled in terms of kind of the talk we're talking about today, which we'll go on to discuss in depth. I'm also co-founder of a holistic wellbeing company. So we specialize at Ardere. We specialize in a private wellness clinic. We have nutritional therapists. We also have psychologists, one-to-one private practice, and we also have self-care products as well. And so I very much specialize in bespoke, personalized nutrition and all those areas listed on the screen here, as Amelia already discussed. And you can find more about me on Instagram. Those are my handles below. And of course, today we're going to be talking and kicking off this webinar series, which is all about medically unexplained syndromes. So medically unexplained syndromes, they refer to a group of conditions which are essentially characterized by chronic symptoms that lack a clear or consistent organic medical cause, despite having thorough medical investigations. And these syndromes can often overlap in terms of their symptomology and also be quite challenging in terms of diagnosis and treatment, especially from a medical point of view. And obviously we've got the common examples listed here below, which of course every week for the next 3 weeks we are kicking off with a different topic. Today is chronic fatigue syndrome. I believe next week is IBS, and then the final week fibromyalgia, if I'm correct. And so of course today we're going to be talking in more depth about chronic fatigue syndrome and really where this kind of issue has kind of taken place in terms of medically. There has been a lot of kind of misunderstanding and stigma around chronic fatigue syndrome. So we're going to go into a bit more depth about CFS, about the naming of the condition, and also how as functional practitioners we can really stand in good stead with our patients and really support them in terms of functional medicine support and really digging down into the root cause. But just to define the word syndrome, so a syndrome refers to a constellation of signs or symptoms, and the word comes from the Greek syndromos, which means running together. And so symptoms of a syndrome, they may not always be 100% consistent between patients, and they can also change over time. So they can have this kind of relaxing and remitting pattern, and they don't always have this kind of medically identifiable cause. So they can kind of have this overlap in terms of, for example, the list that we've seen on the previous slide, a lot of those symptoms of each other can certainly overlap. So we'll go on to talk about that. So chronic fatigue syndrome, just to kind of define it, it's a complex chronic illness that significantly impacts the lives of those who experience it. It impacts various bodily systems, including our neuroendocrine system, so our hormonal system, our nervous system, our digestive systems, our gut microbiome, and also our immune system. And what we're starting to see is that, obviously, yes, there's a lot that we don't know in terms of CFS, but there is a lot of evidence that we are starting to mount up in terms of our understanding of CFS, is that there is really this kind of dysregulation between these systems and these functional systems, really helping to explain kind of the cluster of symptoms that we see in chronic fatigue syndrome. And we'll go on to talk about that. So some key symptoms that we're seeing in CFS. I think one of the first symptoms, of course, persistent fatigue is obviously the first thing to say, where you're waking up, you're not being refreshed by sleep, and you are just in a constant state of exhaustion. But one of the actual hallmark symptoms, and that's why I've highlighted it here, is this idea of post-exertional malaise, and that is kind of the key cardinal defining symptom of CFS, and it's part of kind of the diagnostic criteria that is needed for making a diagnosis of any CFS. And post-exertional malaise is essentially where that person really kind of goes past their energy envelope, so past their energy threshold, and they are met with, I call it payback, this kind of payback of symptoms, a crash, so feeling worse after exertion. And it doesn't have to be kind of necessarily like a high level of physical exertion. It could be something as simple as walking to the other end of your garden or going up the stairs, for example. And also, it doesn't necessarily always have to be physical activity. It could also be cognitive or mental tasks that are also causing this post-exertional malaise, these payback symptoms. But broadly around that, we also tend to see a pattern of cognitive impairment, so things like memory problems, brain fog, kind of trouble recalling the right words in a sentence, loss of balance and vertigo, sensitivities to chemicals, smells, sounds and lights, heart palpitations, flu-like symptoms. We also see orthostatic intolerance, and that's essentially where we feel worse upon standing up. It broadly crosses over a little bit into kind of the POTS category, so postural orthostatic tachycardia syndrome, which is an abnormal increase in heart rate upon standing. So we tend to see people feeling worse upon kind of standing up and moving around. Muscle pains as well, stress-related symptoms, so kind of difficulties tolerating stress, so kind of that stress threshold has been lowered. Food and alcohol intolerance, and very interestingly, as I said earlier, you know, with these medically unexplained syndromes, we're also seeing that, you know, actually with CFS, for example, and IBS, there is actually an overlap. And there was a study that was published in the Archives of Internal Medicine that 92% of CFS patients experience irritable bowel syndrome. So in most cases, actually IBS had preceded the onset of the chronic fatigue syndrome. So there is a real big overlap. And actually, I forgot to mention my own journey. The reason I got interested in CFS and why I work very, you know, clinically with chronic fatigue cases is because of my own journey with chronic fatigue syndrome. So for me, it was when I was at university over about 12 years ago now. So I caught a viral infection, and it was a classic never been well since of, you know, all of these symptoms. But I'd also had a history of IBS. So it's very interesting how, you know, the studies are starting to kind of showcase there is this overlap there. And so we do tend to see kind of these GI symptoms of bloating, constipation, alternating bowel habit. So very much kind of overlapping with IBS. And it's important to also say as well with CFS, it's a spectrum disorder. So not every patient that has chronic fatigue syndrome presents the same way. So on one end of the spectrum, you have kind of those mild sufferers, those who are maybe mobile, they're still in work or education, but they're struggling with their functioning and just struggling with daily symptoms. You know, they're really struggling to get by. Perhaps they go to work, you know, Monday to Fridays, and they're spending the weekends crashing and sleeping because they're just, you know, they're almost kind of just running on exhaust fumes, if you like, trying to get through the week, and then they're struggling thereafter. Then you've got moderate sufferers, and that's those with reduced mobility. Maybe they've stopped work or education, or they've had to make some adjustments like working part-time. And then unfortunately we have the severe end of the spectrum. So this is 25% of the total CFS population. And if we think of chronic fatigue syndrome in terms of how many people it affects, it's 250,000 people estimated in the UK and 24 million people globally. However, I would say that that figure is perhaps underestimated, especially due to the problems due to diagnosing this condition, and also the overlaps now obviously with post-viral fatigue and long COVID since the pandemic. So 25% of this patient population are either housebound, wheelchair-bound, or bed-bound, and some can have difficulty with speech and swallowing. So it can be very, very severe in 25% of this population. And it's also important to say as well is that because chronic fatigue syndrome is a spectrum disorder, I think it's really important that this, you know, we're all more aware about this, because certainly in my case, I was met with stigma because I was ill with it, and I was met with kind of this assumption that because I wasn't in a wheelchair and because I'd say I was mild to moderate, I wasn't severe, but because I wasn't severe, then I wasn't classed as having it. So people kind of negate the illness, and because there's so much misunderstanding around, as I say, it's a functional disorder. It really impacts our ability to function, but that can vary on a spectrum. So for some people more so, and for some people less so, but it doesn't mean to say that on either end of the spectrum it's not debilitating. Just if you're not severe and you're mild, you know, it's very, very much impacting these people's lives and my clients' lives. So just obviously something for us to be more aware about. And a bit more background in terms of kind of the terminology. So CFS has been known by various names throughout its history. So we see myalgic encephalomyelitis, which we'll go into on the next slide, post-viral fatigue syndrome, and even it was colloquially, can't say the word, referred to as yuppie flu during the 1980s. So due to being basically having this widespread prevalence amongst kind of young working professionals in the city. And more recently, obviously, we see this term long COVID coming into the mix since the pandemic. Often it was associated with people that have been basically becoming unwell with, I'd say, kind of an often mild SARS-CoV-2 infection. So they weren't hospitalized, they were ill at home with the infection, and thereafter then they're starting to mirror the classic symptoms of chronic fatigue syndrome. And whilst experts are still, you know, really actively researching whether long COVID is a distinct condition from chronic fatigue and ME, there is a substantial overlap between the two, with many patients receiving a diagnosis of post-COVID ME CFS. So, you know, the jury's still out on that one. Obviously, we are seeing this huge overlap. So I think it's all part of this umbrella. Okay, so kind of just going into a bit more depth in terms of the name. So as I say, you hear this a lot, ME, CFS. So we break down myalgic encephalomyelitis. So to actually break that term down, myalgic, so my is a shortened form of myo, which means muscle. Algic is the adjective form of algia, which means pain. And then we have encephalo, which means brain, myel meaning spinal cord, and itis, of course, meaning inflammation. So if we were to kind of break that down, it's basically saying that this is an illness of muscle pain and inflammation of the brain and spinal cord. And that was a term that was introduced by the Lancet after an outbreak at the Royal Free Hospital in London in 1955. But it's not a pathologically proven explanation for what is going on within this illness. So yet we're still left with this kind of long and confusing name. On the other hand of that, then we see chronic fatigue syndrome. And, you know, this also has a bit of stigma attached to it in the sense of, for a lot of the patient community, it's been thought to kind of trivialize their level of suffering. I often say it's a bit like saying, you know, somebody with Alzheimer's disease has chronic forgetfulness syndrome, because it's trivializing the debilitating nature of that patient's experience, especially if there's somebody, you know, that's severely housebound, wheelchair-bound, bed-bound, it's not just, oh, feeling tired all the time. I think that's where that kind of comment comes from people who tend to see, you know, when they hear about chronic fatigue or post about, oh, isn't that just where you're tired all the time? Oh, well, I'm tired too. But it's a totally different level of debilitating and obviously impacting your ability to function. So also, some experts posit that ME and CFS are slightly distinct from one another as conditions, maybe in the same way people think long COVID could be slightly distinct. But actually, I'd say it's too premature to say that these are distinct from each other. And in fact, the medical literature often refers to the two synonymously. So you've got ME/CFS. I just refer to it as chronic fatigue syndrome, despite my qualms about how it trivializes it, just because it's the most kind of easy to, I guess, access for people to get their head around for the time being. And of course, as we learn more, maybe this might change. But you see all these other different terms thrown around: yuppie flu, systemic exertion intolerance disease, adrenal fatigue, burnout. Interestingly, burnout is not actually a medical condition. It was a term coined by a psychologist in America in the 70s. And actually, it's a list of symptoms, a few similar to CFS, which is fatigue, exhaustion, low mood, but more resulting from severe stress and high ideals that are induced by professional setting. So it's more an occupational phenomenon rather than a medical condition per se. So yeah, as I say, you've got this huge kind of list of names. What we're going with today is chronic fatigue syndrome, and it all forms part of this umbrella. So whilst we don't know fully in terms of kind of from a medical standpoint what causes ME/CFS, we are starting to find kind of, well, evidence that is pointing towards genetic links. So we're seeing infectious triggers, cellular immune-driven problems in the body, including problems with the mitochondria, so those energy-making factories within our cells, and also within our gut microbiome as well, and also our hormone function. So I'll go into detail about that later on. And one of the reasons that ME/CFS is such a hard illness to understand is because we may be looking at this kind of umbrella of etiologies and subtypes within this cohort of patients. And that's where, you know, each patient presents with a nuance behind their symptom clusters. So if you look at this kind of here, within this umbrella of chronic fatigue syndrome, patient A perhaps has one kind of driver that's maybe more distinct from patient B. And yes, there are potential similarities and patterns that we're seeing, and the evidence is starting to showcase that, but there may be slight nuances. And this is why medics and researchers and scientists are finding it so challenging to really understand. And that's where us as functional medicine practitioners can really come into our own, because for us, and certainly for me clinically, it's about working with each patient as an individual. So that person that's sitting in front of me is entirely unique to the next person. And that's really where, you know, functional testing has its place, which we'll go into. So in terms of kind of this root cause approach, the way that I like to talk about it, and I talk about this in the book in more detail, is that CFS, chronic fatigue syndrome, follows a three-pronged structure. So we have the predisposition, we have precipitating triggers, and we have perpetuating factors. So the predisposition is this kind of genetic predisposition. So we know now from studies, and studies are starting to showcase, that there are genetic links that make somebody more predisposed to developing chronic fatigue syndrome. In fact, in 2020, there was a large study in Norway that looked at two versions of genes called alleles, and these are part of the HLA, the human leukocyte antigen family. And these are basically helping to make proteins essential for the immune system to recognize different pathogens. And what scientists have found is that these are more common in CFS patients than in healthy people. And this is a finding that points towards problems with the immune system in CFS. And also, there's a huge study happening now in the UK called the Decode ME study, and it's looking at genetic links into what makes somebody more or less likely to become unwell with ME/CFS. So we do know there is this kind of genetic component. We have twin studies that have backed that up as well. But then also precipitating triggers. So one thing that is clear is that, you know, there is often more cases than not. I will say not always, because sometimes clients find it and patients find it hard to sometimes ascertain why they or how they've become unwell at which point, whereas others, there's very much this distinct classic never been well since scenario. So for a study that was recently done on precipitating triggers, 72% of patients reported an infectious illness upon becoming unwell with chronic fatigue syndrome. So whether that's the SARS-CoV-2 virus, It could be Epstein-Barr. I suspect in my case it was Epstein-Barr virus. It could be also various other infectious agents like Coxsackie virus, cytomegalovirus. There's a whole host of different pathogens, even potentially microbial or parasitic, that can trigger the onset of CFS. We also know that 28% of patients had no apparent infectious trigger, but instead reported a traumatic event such as a car accident or a fall or a surgery. I recently had a gentleman come to see me. He was perfectly healthy all the way up until his mid-30s, and then he'd had an operation and had a metal plate put in his wrist for an injury he'd received at work, and he has never been well since then. So since that operation, never been well since. Also, we've seen in the studies as well, stressful life events have also been reported to be very common in the year preceding the illness. That's certainly the case in the case study that I'm going to talk about later on. And yeah, in my clinical experience, approximately, I'd say about 90% of the patients that come to see me report having had a recent trigger infection. But some cases it could be a vaccination that's potentially made them unwell, and surgery like breast implants as well. So you have this trigger episode, and then what we see is this kind of perpetuating factors, these kind of driving mechanisms of what's still kind of driving the situation, and has potentially been has been set going by this trigger episode, whether it be infection, the surgery, the trauma, the stressful event. And that's this idea of dysregulation, and also these chronic stressors, and we can group these into deficiencies and toxicities, which I'll explain more about on the next slide. So dysregulation. So every single day, our body is faced with certain demands. So we have internal demands like having to kind of break down our food after eating a meal, regulating our sleep cycle, our circadian rhythm, for example, just functioning our brains so that we're alert and we're able to process things, and also recover from physical exercise. In addition to that, we can also encounter injury or infection, which are more of these additional internal demands. And then we have external demands that are related to our environment. So coping with whether it's kind of toxic, pollution in the environment, or whether it's pollen in the summertime, or even changes in gravity as we're moving around, our posture, our body temperature. We have all these different physiological feedback loops and systems that work in a tightly controlled manner in order to handle the various demands sufficiently. And this is a form of balance known as homeostasis. So something kind of, as one thing kind of changes, something kind of offsets that. And that's how our physiological feedback systems work in this kind of homeostasis pattern. What happens in ME/CFS is this idea of dysregulation, which is where the body's systems are becoming imbalanced. So if we look at that seesaw at the top there, you've got homeostasis as kind of at that level playing field, but in dysregulation, we see the seesaw tipped, but it's not coming back into balance. The body is somehow unable to handle basic daily demands due to disruptions in these physiological mechanisms. And so if you look at that web there that I've just showcased, which is a diagram from my book, these are kind of all the areas that we're now starting to find evidence of issues going on within CFS patients. So if we talk about the autonomic nervous system, we're actually seeing evidence that showcases that CFS patients are almost in this state of sympathetic nervous system arousal predominance. So this idea of dysautonomia, the nervous system is not quite firing correctly. It's not going back into kind of this parasympathetic state, but actually almost their autopilot is this fight or flight response. In addition, we're also seeing kind of these digestive system imbalances. So issues within the microbiome, for example, where we're seeing evidence of reduced levels of these commensal bacteria, so these friendly bacteria within the gut, and also specifically a species called bifidobacteria, which are very, very important to regulate our immune system. So we're seeing reduced levels of those in ME/CFS patients. In addition, GI infections are also quite commonly associated with CFS. So things like parasites, so blastocystis or Dientamoeba fragilis, candida, so yeast, and also viruses. So we have this whole community of viruses that live within our gut, and that makes up the gut virome. And we're also seeing kind of imbalances there that potentially are giving us insights as to how this is impacting these widespread symptoms. The mitochondria, so there's energy factories within our cells. We're also seeing reduced levels of the ATP molecule, which is that energy currency molecule that they produce. And that can actually be a big explanation as to why we're seeing this symptom of post-exertional malaise. So this idea of feeling worse upon exertion is because actually the body is not recycling ATP quick enough. So the body, basically energy demand is exceeding energy delivery. So we're having this slow ATP recycling and a reduced level of ATP. So the mitochondria aren't able to produce enough energy, essentially. Also the immune system, of course, we know infections are a big part of this puzzle piece, whether that's acute or chronic. So an infection could be acute, i.e. you could have cleared the infection, but your body's still having an ongoing immune reaction to it. So this autoimmune response. If it's chronic, perhaps the virus is laying dormant and it's reactivating, so it's kind of relapsing and remitting, and it's really about getting the terrain right so that we can deal with these pathogens appropriately. And also we're seeing increased levels of inflammatory cytokines, so inflammation is a huge part of this puzzle. And then when it comes to hormones, we're seeing in some patients with CFS, reduced levels of T3 and T4 hormones, in the absence of kind of a diagnosis of like autoimmune thyroid conditions or even hypothyroidism in general, and also lower levels of cortisol, especially after a period of what we can see initially of high cortisol levels. So a period of really this kind of low cortisol, which is essentially where the adrenals have started to flatline, where we're seeing adrenal insufficiency. So that's just a little bit of a web of dysregulation. And just in addition to that, we kind of group it into this chronic stresses pattern, where we're also potentially seeing added to the mix maybe nutritional deficiencies. Stress and trauma are also a huge part of this pie, and also toxic agents. So sometimes clients can come to me after maybe it's an exposure to whether it's mold, like sick building syndrome, they've moved into a new house, there's a lot of mold around, and then they've developed this illness, or whether it's pesticide exposures, potentially if they work in agriculture on a farm, for example. So that can also be part of the mix. And really, as I say, it's about finding the needle in the haystack. So for us as practitioners, you know, these are the root drivers that have been correlated at the heart of CFS. So clinically for us, it's about unpicking that mosaic of fatigue and really understanding what are the perpetuating factors for that person in front of us and what are the driving agents. So ultimately, whilst there are similarities between cases, we have to consider that each patient is entirely unique. So our job is to really apply our functional medicine detective lens to consider what is going on for them as an individual and what that third P is, as I said, using scientific evidence, using functional testing. And just a final kind of note on, you know, kind of the NHS and this kind of medical approach is that, first of all, you know, the diagnosis of ME/CFS is a diagnosis of exclusion. When your doctor can't find anything wrong with you, ME/CFS is kind of the only explanation left if you match a certain symptom criteria for a period of 3 months. And the reason being is because there's no standard NHS medical tests for ME/CFS. We do have studies now going into, I mean, Stanford University in the US, they're looking at a test at how the immune system cells are responding to stress, almost as a future diagnostic test. But of course, we don't have a specific test for us to say, yes, you have it, no, you don't have it. So it's really about following kind of distinctive patterns and features in terms of symptoms. And of course, not always all the symptoms will match from one patient to another, but there are a list of diagnostic criteria within the NICE guidance system. And so it's about matching that, obviously excluding out any other possible causes of fatigue, and there are other symptoms. Of course, the fatigue is a huge broad symptom that crosses over into many different categories. So it's excluding any other causes and then seeing where you fit. And there's no international agreement on classifying these symptoms as well, or even what to call the condition. So within the US, there's a different diagnostic criteria against the NICE system, which is in the UK. So as I say, this is where kind of the NHS, you know, I guess falls short in terms of its support. And really, these are the kind of medical approaches that you see within the NHS for ME/CFS. We know that the NHS care model is not particularly very well set up for chronic illness and chronic disease management. You know, it's currently crippled as a service, and we know that as nutritionists, as functional practitioners, we can really hone in on this, because long term we offer that hand-holding, that really focused one-to-one support for patients to feel heard and supported, and really we're looking into those root drivers, so we're asking the right questions. But you know, you can see here that you've got cognitive behavioural therapy, which is a form of talking therapy that works to support changes in the way people think and behave. It's used in a lot of other conditions as well, but actually it was previously positioned as a curative therapy for ME/CFS. And it was used alongside graded exercise therapy, which has since been scrapped from the NHS due to controversy. And these therapies gained momentum because of a study in, I think it was 2011, called the PACE trial, which was funded by the UK Medical Research Council. And the theory behind using CBT graded exercise is essentially a structured exercise program where you increase physical activity levels basically without listening to patient feedback. So if the patient feels worse, you're still almost kind of being told to keep increasing. But essentially, it was found that patients were feeling worse upon doing this. It was making their ME/CFS a lot worse. But the theory behind using these was almost based upon the view that patients were feeling their symptoms because of inactivity and deep conditioning, as well as holding negative illness beliefs. And of course, that really fails to take into account the fact that this illness is physical. It's not psychological, and it's this idea that, oh, well, simply thinking more and, thinking more positively, should I say, and moving more is the better way to go to get better. But of course, this kind of was then investigated further, and there was a lot of outcry from patients, researchers, charities about it making patients worse, especially the GET. That was then taken off the NHS support programme. Now they use CBT, but more as it's been reframed as a support tool for the psychological effects of dealing with a chronic illness. And I think that's where it then starts to have its benefit, because I think previously patients weren't responding well to it because they were kind of being, I guess, medically gaslit into thinking that actually, oh, your symptoms are more as a result of mental health reasons versus it's a physical condition. So now that that's been reframed as, okay, this is about us supporting you psychologically with the physical impacts of what you're going through, then that actually then does have that therapeutic effect. So I think that reframe has been very welcomed amongst clients of mine. So I also just wanted to kind of pinpoint this, which I saw on a leading CFS charity, is that they kind of use this term of, there's no effective drug treatment and full recovery is rare, but symptoms can stabilize and improve over time with careful management and specialist support. And just kind of highlighting there, full recovery is rare. It's a very pessimistic way of looking at ME/CFS. And I think when you do go online and you look at a lot of the stuff that you do tend to see online with ME/CFS, it is very pessimistic and it's very doom and gloom. And I think it's really important that we have the context here, is that actually, what is that going to say to the person who's newly diagnosed and as their outlook on their prognosis? How will that shape their beliefs on recovering their health back? Because it's so important that we're optimistic, that we challenge any negative attitudes or beliefs on them recovering. We know that it's possible for patients to recover. I'm an example, my clients are examples, and there are so many people out there that do get well. But I think just really kind of challenging that, and I think this quote is very important to hold on to there, is that if something is not impossible, then all of a sudden, by some margin, it becomes possible. So we really need to hold on to that positive outlook, especially as we're beginning that journey and that chapter in recovery. So let's move on to my case study. So my client, Lucy. So she's 34 years old, and she was, well, essentially a senior consultant working in the city. She'd taken a leave from work around November time of last year due to poor health, and she had 3 bouts of COVID close together in 2023 and was struggling with a never been well since situation. So she came to see me early 2024, and the symptoms she was experiencing was chronic fatigue, post-exertional malaise, brain fog. She had light sensitivity, so every time there was bright light, she was feeling triggered. It was making her symptoms worse. Dizziness, memory problems and concentration, sinusitis, GI issues, and also anxiety and low mood. The ones in yellow I've highlighted, those were kind of her main presenting symptoms that she was really wanting to work on. And she did have a medical diagnosis of CFS, so she'd ruled everything out with the doctor. And also she'd had a history of IBS prior to this, which was very interesting as well. She was also an A-type personality, so her self-esteem was intrinsically connected to her work achievements, and she was keen to get healthy so she could get back to work ASAP. So she was really kind of driving herself, like, need to get better so that I can get back to work. So there was a little bit of nervous system. I could sense that just upon meeting her, she was very, very tense and just very stressed about the fact that she was off work. and that she'd taken this time off work. She really wasn't giving herself permission to have a period of convalescence, which was interesting, and you know, that stress picture certainly seemed a big thing for us to investigate. So in our initial consultation, we had thorough health assessment. I asked her to complete a food diary before seeing me. We went through all of that, really kind of delved into everything from her past health with IBS, any medication she was taking. I also requested a battery of GP tests as well, so just to make sure that we knew exactly what her levels were of things like B12, vitamin D, folate, for example, and also iron, her thyroid, etc., just to kind of rule out any anemias, any nutrient deficiencies, which of course is a really good first point of call. And then we also looked at kind of what those kind of key antecedents were, the triggers and the drivers, and really what warranted more investigation. So for her, it was a stressful time of pushing herself work-wise. You could see that she just did not let herself rest. She also was on a frequent bout of antibiotics because she was constantly getting unwell with infections. And of course, then the big kind of straw that broke the camel's back was this SARS-CoV-2 infection, or a multitude of them over the course of late last year. And what we could see, what I could certainly observe from her driving pointers, was that she was stressed, she was resisting the situation, she was really impatient to get back to work, as I said. She was also under eating as well, so she didn't have an eating disorder as such. She had a sister who had an eating disorder, but she'd kind of followed a similar pattern in sense of she was not eating a lot of food and she was aware of it. So that was certainly something that, you know, we really wanted to focus in on. And there was also obviously these suspected food intolerances. She noticed fiber was a big trigger for her, so we wanted to investigate FODMAPs. And also she had these kind of gut symptoms as well. So kind of, again, thinking we really kind of need to look at what's going on within the gut. So what did I recommend as next steps? So I recommended Genova's chronic fatigue screen test and also Genova's GI effects stool test. So the reason for this approach was really kind of identifying the key symptoms that she had, and also obviously exploring that personal health history and considering the best test. Of course, also understanding the means and her budget and really where she wanted to go with this, but she was really, really keen on doing some testing to really gain more answers and insights. Obviously, her symptoms was the fatigue, the gut symptoms, the cognitive symptoms, also the anxiety. So this really gave me an insight of kind of where I made my decision. If, as a practitioner, you are just, you know, maybe struggling to make a decision on what test is best for your client or your patient, then Genova do have a really fabulous service on their clinical education portal where you can, you know, book a call or a consultation to really find out what might be the best test for your case or for your client, and you can get some support that way. Essentially, I went for, as I say, the chronic fatigue screen. This is 2 tests in one. It's an adrenal stress profile. It has the option for a cortisol awakening response add-on, and then also the organic acids test. And the organic acids is essentially where we're looking at these urinary metabolic byproducts that accumulate within your urine, and they give you an insight as to various different levels of your functional health, from your mitochondria and your Krebs cycle and specific cellular demands in terms of nutrients, what we need. But also we're looking at kind of toxic exposures, liver health. We're looking at a bit in terms of the GI tract as well, in terms of what might be going on there, oxidative stress. So we can see a real lot in terms of understanding how this can fit into the fatigue picture. And yeah, so just kind of, as I say here, knowing what I know about CFS and the picture of root causes, why I recommended these tests. Of course, she had a chronic stress picture, so that was certainly the case that we needed to look at her adrenals and cortisol levels, suspected cellular stressors due to the viral trigger, working in the city. Again, organic acids, we can look at the mitochondria, her nutrient demands, inflammation, oxidative stress, and of course, her history of IBS, the antibiotics that she was on, and these frequent gut complaints, which were really bothering her, was the need for kind of, okay, we can really gain a bit of an insight from really looking at her gut status and gut function. So yeah, just to kind of say as well, you know, functional testing, it gives us an insight into a client's functional systems, really delving into those biochemical imbalances, which is really important for complex unexplained medical illnesses like CFS, long COVID. And this is where these 2 tests really provided a point of reference for these chronic stresses and a pathway for personalization. So we're really kind of able to delve into exactly what we've identified and picked up. So the results. So this is her adrenal stress profile. We're looking at her cortisol levels, her DHEA. These are kind of her two major stress hormones, and wow, you can see just how high and elevated her stress response is. The first box on the left is her cortisol awakening response. So that's basically her morning time response of cortisol, which is essentially meant to follow this kind of triangle pattern of kind of, we see this rapid rise in the morning and then starting to taper off as we move throughout the day. What you can see for her is that it already on waking, it's very, very high, but it's not actually rising that much. It's then starting to taper off, but it's not throughout the rest of the day. As you move into this box here, she's very, 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 very stressed. So you can see that cortisol activation, and even just into the 10 p.m. to 12 a.m., she is really firing sky high there. So she's not really having any kind of recuperating effects from that stress response either, because her DHEA is also on the low side. So you've got a low DHEA level and DHEA cortisol ratio. So DHEA almost has this kind of, they're like a bit of yin and yang, cortisol and DHEA. So DHEA basically counterbalances the kind of catabolic effects of cortisol. It has this kind of anti-inflammatory ability, but she's not really getting any result from that or response from that. And it's just this wear and tear effect on her system. So she's just very activated. And then we look at her GI effects. We'll move on to the organic acids part in a moment. But her GI effects, you can see that she had elevated levels of fecal fats and also protein breakdown products in her stool. Now, she wasn't eating a very, very high fat or protein diet. And of course, she was, really following a pattern of really under eating. So for her, it was, I was suspecting this was related to the fact that she had a very, very high secretory IgA. So secretory IgA is your gut's most abundant antibody. The fact that this was firing very high suggested to me that she, was, well, first of all, we have picked up a pathogen, which we'll showcase later on in a moment. But that she's got this very high immune activity, but also that can be really impairing the integrity of the gut lining. And this is where I'm thinking, okay, compromised gut barrier, intestinal permeability could be driving those scores high on the digestion and absorption scales. So her short chain fats were good, her beta glucuronidase was within range, but as we move on to her commensal pattern, actually it's just pretty good. She had relatively good balance of commensals, although kind of lowish levels of lactobacillus, which we do know play a role in digestive health and also, helping with the integrity of the gut barrier. And interestingly, her levels of bifidobacterium, which you can see here, were also within range. And that's actually a good thing because, as I say, we know that they're really beneficial for supporting and educating the immune cells to work. And actually, studies have showcased a pattern that they tend to be low in ME/CFS cohorts, but for her, this wasn't the case. So really just looking on this page, not too worrisome. But as we move on to the kind of the parasitology and the kind of pathogenic microbes, we picked up blastocystis, which, as I say, is it's basically a protozoa or a bacteria, not bacteria, parasite, which can be associated with a lot of GI complaints, so abdominal pain, bloating, flatulence, IBS symptoms, and of course has also been associated with chronic fatigue syndrome. There is some controversy around the fact that parasites can be detected in healthy and symptomatic patients. So sometimes there's kind of controversy around, do we do anything about it in terms of if you went to a GP? However, if we know that we've detected this and we know she's got these medically unexplained symptoms, why are we not going to go in and really address this? We certainly should. So it's something we've spotted and it could certainly be driving what's going on. So it's, it's really good that we've detected this. And then also we've seen levels of a potential pathogen, Enterobacter clochiae. I can never pronounce these correctly, so forgive me if I'm mispronouncing any of them. And then levels of Citrobacter and Candida albicans were detected, not at a high enough level to become problematic, but they could become opportunistic in the future. So again, it's really about thinking about how can we deal with this gut environment and support that. And her organic acid results were showcasing a need for B vitamins and manganese. So we know that obviously B vitamins are very, very important as cofactors for ATP production within the mitochondria. Even when we're stressed as well, we deplete levels of B vitamins. So due to her chronic stress picture, we really need to be thinking about B vitamins for her. And then if we look more broadly at the kind of organic acid markers, I'll whip through this very quickly, just being mindful of time, but essentially you can see her A few of her malabsorption markers just up here were elevated, which linked with her stool results. The dysbiosis markers were relatively elevated as well, and I think that this is not specifically related to the fact that her commensals were, obviously we know her commensals were fine, but actually those dysbiosis markers of the potentially pathogenic bacteria and the parasite that were detected on the stool test could be driving these organic acids up. We also see her yeast and dysbiosis markers elevated as well, so that also points to that pattern. This ratio here is looking at the kynurenic and quinolinic ratio. Because this is out of range, we know that this is has a capacity to be associated with neurotoxicity, so neuroinflammation. So because she had a lot of cognitive symptoms, this was speaking to me a lot in terms of, okay, this could potentially be showcasing that we have not just inflammation happening within the body, but actually inflammation happening within the brain. And this could also be driving what's going on in terms of the brain fog, the cognitive impairment, and that's definitely something we really wanted to work on together. She had high serotonin breakdown product markers. She was on an SSRI, and also she did have those raised dysbiosis markers. So there could be a link between that. I think potentially the SSRI medication. And then toxin and detox markers, not hugely elevated, but there was some exposure to petrochemicals. Again, sometimes we can't always do a lot about that living in the city, for example. But what this does showcase is that we can really go in with some support in terms of her cells and looking at antioxidant support. So again, just further on the oxidation point, she had moderately elevated levels of 8-hydroxy guanine, dinaguanine, I can never pronounce them, and that's basically, it's a 8-OHDG. It's formed when DNA is damaged by a reactive oxygen species. So we know that, as I say, if that's elevated, we are seeing some oxidative damage to DNA. We really want to support her cells as much as possible, because of course everything that's happening within the body, happening on that cellular level, energy manufacture is being done on a cellular level. If that cell is being in any way damaged from a DNA perspective, but also from the outer layer perspective, when we look at these lipid peroxides, then we're not able to manufacture proteins efficiently, we're not able to repair things, we're not able to produce ATP effectively, we're not able to manufacture energy and do our jobs. So this is where this really comes in. So as I say, we can see moderately elevated urine lipid peroxides, and these are a class of free radicals that damage that fatty coating on our cell membranes. So all of these things that we picked up are really feeding into that picture of chronic fatigue syndrome. So what did we do? We went in with a protocol of antimicrobials, so berberine and oil of oregano for a period of 8 weeks. So yeah, we really wanted to kind of give that enough time. Sometimes they can have a high, herb resistance or drug resistance, blastocystis. So it's really thinking about kind of making sure we kind of go in strong with that for a period of 8 weeks. And of course, going low and slow. So kind of really just making sure that, she's responding well to those and not having any negative feedback to the supplements, because sometimes we do get a bit of kind of, aggravations, and sometimes you do have to kind of taper that approach. We also went in with with a methyl B complex, with a family of synergistic B vitamins as a mitochondrial cofactor. And we know that obviously a lot of people have the genetic polymorphism where they can't methylate effectively. So really that's where we went in with the methyl B. Another thing that's really powerful, when we talk about the urine lipid peroxide, and also there's oxidative stress markers, is this fat called phosphatidylcholine, and it can really help to restore integrity of that fatty coating on the cell membrane. So it's really going to be supportive for kind of cell function, neural firing, and just really kind of coating and protecting those cells. Ashwagandha we used as an adaptogen to really support and balance her cortisol response. NAC, that was used as a precursor to the body's master antioxidant glutathione, and also a specific type of it, interestingly, called augmented NAC, is being studied as useful for denaturing the spike protein in SARS-CoV-2 infection. So we went in with an augmented version, and then we switched after about 6 weeks' time to a more cost-effective version, because the augmented version is a little bit more expensive. But this was fantastic for not just supporting her liver, like detoxification pathways and that oxidative stress, but also helping in terms of the citric acid and Krebs cycle, and supporting with that ATP production. So it's just a general kind of really fantastic thing to add in, because it's just supporting your cells and supporting those mitochondria. D-ribose is another fantastic mitochondrial agent, which I use in pretty much most, or if not all, of my CFS clients. And it's a powder, so you can take 1 teaspoon and then start to titrate it up. With Lucy, we managed to titrate 2 to 3 teaspoons a day, 2 to 3 teaspoons a day within the 3-month period. And that is something that really does have a fantastic effect when people are experiencing post-exertional malaise. Zinc carnosine, really fabulous for restoring integrity to the gut barrier and dampening down inflammation. And that can also support that, that high chymurinic quinolinic ratio, which we saw in her organic acid report, and also can bolster stomach acid levels. So we need to kind of get stomach acid levels strong to prevent reinfection of future parasites or pathogenic microbes. So that's also another factor of where the zinc carnosine came in. Omega-3s for cognitive support, reducing inflammation, and just fantastic in terms of brain health. And then what we did afterwards, so we kind of did the 8 weeks of weeding with the parasite, and then we went in with a multi-strain enteric-coated probiotic complex, which had kind of multitude of different strains. Of course, her commensal pattern was already pretty good, but because we've done some antimicrobial work, it was really about making sure we supported with a broad range of bacterial species. And we went in with those for a period of 6 weeks, and actually we're now moving across to partially hydrolyzed guar gum, which is a prebiotic fiber. Basically, it's a non-FODMAP, so it's basically going to help to support microbial diversity going forwards, and it's a really useful and versatile supplement to have going forwards. So just in kind of, obviously I'm being mindful of time because I want to leave time for questions as well, but this was kind of what we did nutritionally. We made sure that she was consuming more in terms of daily calories, consuming 3 meals a day, high in protein, high in those good fats, and also at least a little bit more complex carbs than she was consuming previously. I asked her to do a food and symptom diary to look at any FODMAP triggers. So things like garlic, onion, and leeks actually came out as what were really kind of bothersome for her in terms of those GI symptoms. So we slowly over time, once we managed to kind of rebalance those, really reintroduce after a period of removal, but at a much lower level according to where her tolerance levels sat. Blood sugar was also a key part of that, and that's always a key part I ask clients of mine is, how does a meal make you feel? Does your energy levels feel better after eating, or do they feel worse? That's such a key thing to ask, because it can give you an insight as to whether somebody is hypoglycemic or hyperglycemic. She was on the hyperglycemic spectrum, so we really need to look at meal timings, making sure she was eating regularly and just anticipating any blood sugar dips. We made sure that she was chewing food, making meal times a ritual, having enzyme-rich foods to really support those absorption markers, which we saw in her GI effects test. Also, again, dietary diversity was a big part of this, and making sure she's getting a cocktail of different fibers every week, not just eating the same foods on repeat. Fermented foods as well, of course, after we've done that weeding period, this has been a really important part of her protocol. And things like bone broth. So I've asked her to do, whether she's making some chicken or rotisserie chicken or anything like that, or making it at home, or buying some and freezing them in batches, and just drinking 3 cups of bone broth a week to support the GI lining, because those will contain things like amino acids like collagen, glutamine, glycine, gelatin, things that all really help to nurture and support the integrity of that GI tract, and that's going to really help to kind of counter any inflammatory processes going on. Green leafies, just trying to rotate those, because we know there's very dense in energy and off the cheek fighting nutrients, things like B vitamins and iron, things like magnesium, for example, folate. So we just really need to think about getting those in, which we did. Anti-inflammatory herbs, lots of fluid, and of course manganese-rich foods, which she was demanding more of on her report. I'm just going to briefly brush through this. Pacing, for her, it was about getting through that boom and bust cycle. The boom and bust cycle is where you have a good day, you overexert yourself, then you have the payback, the post-exertional malaise, and then you're left with no choice but to rest. It's about anticipating that from happening, finding your baseline, dropping down your levels of activity to a point of really incorporating rest and convalescence, giving yourself permission to rest as well. That was a massive part of her puzzle, because she just wasn't giving herself permission, and scheduling rest between taxing activities, and making sure she's doing energy giving things each day. So just really kind of getting a hold on that boom and bust cycle. So pacing her activity levels and finding what activities. I asked her to do an activity diary to really kind of see, okay, what's building you up energy-wise, what's breaking you down energy-wise, so what's energy giving, what's energy draining, what's energy neutral, how can we do more energy giving things, and how can we kind of prioritize what's important in terms of the energy drainers, and how can we chop and change that. So it's about really working with her routine. Mindset was also a big part of our work together, dealing with the emotional ups and downs. Crashes are bound to happen. It's part and parcel of chronic fatigue syndrome. It can be a bit of a game of snakes and ladders. So for us as practitioners, it's really about how we can help clients bounce back from a crash. What are the learnings we can take? Reframe them as a learning experience in their journals or their thought diaries. Really working on those achiever patterns, the A-type personalities, and all of these other different fabulous tools of, you know, nervous system support. Giving herself permission to rest, as I say, was really important. And then 3 months after our work together, where Lucy is today. So along the journey, of course, yes, crashes did take place, and that's totally normal, but we did see an observable symptom reduction. And actually it's amazing now because she's able to start to get out the house again. She's going out and meeting friends, and her physical capacity is improving, and she is no longer in that boom and bust pattern. So that's something we've really managed to get a hold on, and her body is more tolerant of activity again. So she's increasing her daily step count without the crashes, and concentration is also restoring. In terms of her gut, we're still seeing a little bit of bloating going on, but we're now starting to correlate that a lot more with stress and anxiety triggers. And she has seen some relief there since she's incorporated those antimicrobials for the parasites, and also identifying those FODMAP triggers. What we're also looking to do going forward is to try and taper off some of those supplements in the next few months, and that is a sign of progress. We don't want her to be on supplements forever and ever and ever. And then we're looking to retest, you know, the GI effects, and also specifically the cortisol towards the end of the summer, to review her progress on her adrenals and the eradication of the blastocystis parasites. So, you know, she's not currently going back to work just yet, but this certainly might be on the cards towards the end of the summer. And I think, you know, for her, I think she's just had to really lean into this period of convalescence because it's so important for her. She's taken the time off work, but she wasn't mentally allowing herself to. And I think now she's kind of really invested in all that she's done, you know, development wise, and in terms of the testing and all the things that we found out, and these mechanisms that we put in place in terms of her nutrition, her supplements, her lifestyle. I think this is all kind of stood her in good stead, and actually, you know, she continues to kind of to go onwards and upwards. So it's really, really positive to see how she's doing. So that's a little bit about chronic fatigue syndrome in a nutshell, and also really how, as practitioners, as I say, we can really delve in using a functional medicine model in terms of understanding those root drivers. And it really is about that kind of personalization approach, because each person that comes to you with CFS, you know, perhaps they have other comorbidities going on as well, but really they are all unique, and it's all about how we can delve into that as an understanding. So thank you for listening. Here's a little bit more about where you can find me, where you can find my book, and I will leave it now for Amelia to jump on and ask any questions if we have them.
Thank you, Lauren. That was such a great presentation, and I think all of us get so much out of hearing those protocols and client case studies especially, so thank you so much.
You're welcome.
We do have quite a few questions, which is great to see. If anyone does have to jump off at this point, don't be worried, you will receive the Q&A as part of your post-event recording as well. So just to jump straight in, someone has asked here, when you're looking at the protocols, can you re-explain what the reason might be for your patient's high levels of fecal fats?
The fecal fats, yes. So she had elevated levels of secretory IgA. One of the reasons why she could have had high secretory IgA was because of the fact that she had the parasite and the pathogenic microbe. So that was amping up her immune activity. But sometimes once the inflammation is quite high, is what it can do is impair that intestinal barrier. And then that can drive up those levels of fecal fats or products of protein breakdown as a result of that impaired gut lining. So that was kind of what basically was the basis for that.
Great, thank you. And then we've got another question. What is the rationale of using antidepressants and the SSRI in particular?
So I guess, well, for her, it was kind of really, she was on it because of the fact that she had low mood. I probably wouldn't be able to medically comment on that one. Obviously, that was under the care of her doctor, but it was really to support kind of the serotonin in her brain and the levels of that. Of course, obviously, we did see, you know, elevated markers on her organic acid report, which, as I say, I think would have been explained by that medication.
Yeah, Great, thank you. Oh, and how many COVID shots had your patient had by interest, if
I
you knew?
think she'd had one, or potentially two. I need to look back at her report actually, but I know she definitely was vaccinated. It wasn't that she'd had the kind of classic never been well since after vaccination. It was the infectious agents that were the trigger for her. But yes, she was vaccinated.
Great. And then there's another question here. Could you please list the genes involved? I think this might have been asked right at the start.
Yeah, so it was the human leukocyte antigens, so the HLA family, and it's two versions of those HLA genes basically, and they make proteins for the immune system to kind of recognize different pathogens, and they've been linked with autoimmune disease as well. I can't off the top of my head remember the specific type of HLA gene, but I think I've listed it in my book actually, but I go into depth in terms of the genetic links of those. But as I say, they're really important for, as I say, the immune system. And what we've found is that, patients of CFS, these were more common in those than the healthy cohort. So, potentially impacting the way the immune system is functioning.
Great, thank you. And then another question, when you mentioned fermented food, do you recommend home fermented as recommended by Dr. Greger or to avoid excess salts?
In terms of kind of what food companies have added, for example? Yes, there's certainly a benefit of, kind of home fermentation, because obviously you've done it yourself. You're much more in control of kind of what's going into it. But what I would say is that obviously if you've got chronic fatigue syndrome, you probably don't really have the energy to be doing those sorts of things. So I think just starting kind of low and slow, if you can access, or you've got the means to pay for kind of, I know they're a bit more expensive than making things at home, but things like, I think the brand that I like is Vadaz. If you can, Vadaz, I think it's spelt. And that's the one that does like the beetroot kimchi and the normal spicy kimchi and different sauerkrauts and things like that. They're a very good brand. But yeah, I'd certainly encourage if it's within the client's means. But obviously, if you've got chronic fatigue syndrome, it can sometimes be a challenge to do all that sort of stuff.
Yeah, and it helps if they like it as well. I love kimchi, but it's very love or hate, isn't it?
Yeah, it really is. And so I often say to clients, if you're struggling to kind of get it in around meal times or with your meals, for example, because you don't like the contrast of the kind of savory versus sour, I just say, just have, when you're eating or just about to have a meal, just literally have a tablespoon from clean spoon from the tub, and maybe, or one or two, do you know what I mean? So instead of kind of having it combined with a meal, because sometimes people just don't like the combination of kind of savory versus the sour. So just have it neat on its own if you like as well.
Yeah, absolutely. And we've got a question here about Genova's testing and how we can interpret the results. So if you've got any questions about our testing specifically, you can head to the gdx.net website, and we've got a full list of our product ranges there. Or you could also email us at info.uk@gdx.net, and you can get put straight into contact with one of our either clinical education team who can talk you through the different testing and what might be useful for your client or your case study. Or you can speak to one of our customer service team just for some general information. So another question here, you mentioned about crashes, and how do they tend to look for a client, and how do we build them back up after that?
So yeah, so crash can, it can be different for each CFS patient because they all vary, right? So kind of common crash would be kind of the worsening of the fatigue after, maybe it's they've gone out and they've gone for lunch with somebody, or maybe it's something as simple as they've just gone up the stairs and they've maybe done a bit more housework than they normally would have done. But for others, it could be that maybe their brain fog's getting really bad, they're struggling to kind of recall sentences, concentration's bad, maybe their GI complaints are getting a little bit worse, or potentially the muscle joint aches and pains. As I say, we're talking about these medically unexplained syndromes. As I say, the symptoms can kind of very much be, I guess, diverse. And so with the kind of crashes, in terms of navigating them, it's about really, what I like to get clients to do is kind of complete an activity diary. Find out what things are energy giving in your daily kind of weekly routine, what things are energy neutral, what things are energy draining or energy giving, if I didn't say either or. And then basically trying to understand and ascertain the things that you're doing on a weekly basis that are really kind of contributing to your energy levels or draining them down. And there'll be certain tasks that potentially, I'd say you part of this boom and bust pattern. If you have a crash, of course, it's important to stop. If you'll notice, also important is getting clients to spot the warning signs, because symptoms can often start to present themselves. And as clients, I find as I'm working with clients, they become much more in tune with their bodies over a period of time of working with me. And then they start to be like, honestly, I'd just go to the gym and I'd like smash out a session and then I'd be like on the floor afterwards. But before that, they wouldn't notice like, or they do loads of things after that and then they'd be on the floor like crashed. But as in what I'm trying to say is that you just don't notice that you have these kind of increasing warning signs of symptoms, where as they're becoming more in tune with their body, they start to realize. So I think as that happens, the pacing narrative is about really kind of pulling back before you continue doing more. And that's where you work on really kind of finding activities that they can do in their day. Non-sleep eat rest is a really good one, which is really finding ways to kind of take 10 to 15 minutes, whether it's doing the guided like yoga nidra or something where literally you're almost kind of doing nothing. You're just whether focusing on the breath, a body part, for a 15-minute period that takes you into the present moment and allows you to rest, because people sometimes think that they're resting, but they're not. And they're not fully giving themselves permission to rest. Maybe they're sat on the sofa watching TV, but they're neurologically not resting. So it's thinking about also the cognitive aspects as well, not just the physical, like, okay, you've gone to the, for a coffee with your friend and you've crashed, but perhaps maybe they've done something else and they've crashed and they've not realized what it was. Like, okay, I was on Instagram, scrolling on Instagram or TikTok for ages and ages, and my brain was just frazzled with information, and then I crashed. So it's trying to kind of piece back what caused it, spot the warning signs, give yourself the convalescence and the rest, and figure out how we can incorporate scheduled rest going forwards. And that's what pacing is all about. But I go into more depth on that in my book, in terms of how you can pace activity levels better, because it's a big minefield.
Yeah, for sure. Thank you so much. I think we had time for just one more question before we get to like 10 past. So to what extent do genetic predispositions play a role in CFS? Are there specific risk factors that we should be aware of?
So I think the science is still kind of ongoing. It's still in its infancy. What we do have confidence to say is that there are genetic links. There are twin studies as well that showcase that it's more kind of likely for in terms of our genes that somebody can be predisposed to becoming unwell with ME/CFS. How that looks, we don't fully know. Obviously, we talked about these HLA, this gene family that potentially makes you more predisposed. Then there's also the Decode ME study that's now finding out more information. So I'd maybe point you in the direction of them to kind of have a look and find out more further as they're gaining more nuggets and insights there. But we still just don't know enough. But what we do know is that there is genetic links in terms of potentially, what can make us more predisposed. We just don't know exactly what, exactly kind of is pinpointing there.
Yeah, for sure. Well, thank you so much, Lauren. That is all we probably have time for today. Next week's session is going to take place on Wednesday next week at 1 p.m. So you can join us for that using today's session link, or you can re-register online to receive a new link as well. Thank you, Lauren, for your time. It was such a great presentation and we've had so many questions, so I'm sure everyone agrees with me as well. And thank you all for joining us today. Enjoy the rest of your very sunny afternoon and we'll see you soon.
Yeah, I hope everyone enjoys the sunny afternoon. I'm going to get out myself.
Yeah, great. Oh, thank you so much, Lauren.